Hi, good evening, and thanks for joining us. I'm Dr. Jane Georges. I'm Dean of the Hahn School of Nursing and Health Science at the University of San Diego. Tonight, we're presenting a panel discussion with 3 African-American nurse scholars and advanced clinicians. And we're going to discuss ways in which nursing education and research could better address the needs of the African-American community. With me are Dr. Trista Campbell, Dr. Kiana Jones, and Ms. Samantha GamblesFarr. I'd like to thank the 3 of you for taking the time to join us for this important conversation. During the past year, the American Nurses Association has identified racism as a public health issue affecting millions of Americans. As ANA President Ernest Grant says, silence is complicity. And none of us as nurses are going to remain silent anymore. At the University of San Diego, we're committed to health equity and finding ways to provide better health care for all Americans. In our discussion this evening, I want to begin by having each of the panelists introduce themselves and talk a little bit about their educational backgrounds as nurse leaders in practice, research, and education. And so, Dr. Campbell, let's start with you. Please introduce yourself and tell us about your educational background.
Again, I'm Trista Campbell, and I have over 40 years of nursing in the field. And believe it or not, I truly started at the grassroots. I went to a 2-year college, and I was in a program called Success in Nursing. It was a program that was customized for minorities. We were African Americans, Native American, and Hispanic nurses entering into the field. And the focus was to be sure that we were competent in our sciences and maths. And in the last semester of the program, we joined the remainder of the cohort. And I really think that was very instrumental in making me who I am today, having that type of entry level into the profession. And I more or less went to school along the way. I ended up getting my BSN in accelerated program, the first cohort at Grand Canyon University. It was a program for experienced nurses getting your BSN. And then I ended up getting my master's degree at Grand Canyon University as well. And I transitioned to California, and I got my PhD at, I'm going to have to say, the most wonderful campus in the world, University of San Diego. It was a wonderful experience, and I share it to this day. And I used to, when I would leave work and leave for school, I would say, I'm going for my spa day. That's how nurturing the program was. It was my spa day. It met all my needs.
Well, I'm sure it wasn't a spa every day, but it was my privilege to be your dissertation chairperson, and maybe a little bit later we'll ask you to talk about your findings from your dissertation, which have direct application to the African American community.
Sure.
So, welcome, Dr. Campbell.
Thank you.
Well, I'd like Samantha to introduce herself now, and she is an adjunct faculty at the Hahn School of Nursing and Health Science.
Thank you, Dean Georges. I am so honored to be here tonight, and I would like to just state that I'm so proud to be an adjunct faculty at USD. The intuitiveness and the leadership that it took to organize this as an important, needed conversation in our community has a lot of foresight, and that's why USD continues to be one of the leaders in nursing. As Dr. Georges said, I'm Samantha GamblesFarr. I am a adjunct faculty member at USD. I'm currently the nurse practitioner at UCSD in surgical ICU and trauma. I started my education as an LVN in Texas. So I have worked my way up, all the way up from LVN. And then I went to one of the few remaining diploma programs in the nation, Covenant School of Nursing in Texas, that was affiliated with the hospital. So we had a strong emphasis on clinicals, and got to see a lot of things because our campus was very large. There was 2 hospitals, freestanding children's hospital, freestanding women's clinic. So my clinicals really helped me adjust as I moved back to California. As I'm a San Diego native, I was born here at Balboa. My dad was in the military. And then I did my bachelor's at Holy Names University. And 6 months later, I went back to school for my master's and got my family nurse practitioner at Holy Names University in Oakland, California. I'm in the process of tirelessly trying to get back on track with my doctorate degree. Life kind of got in the way, but that's okay. We understand that as nurses, we fall down, but we get back up again. So I am working tirelessly on that. And I'm just so happy to be here. I am also the president of San Diego Black Nurses and very involved in a lot of activities as it relates to health equity and community service as it relates to all the people of San Diego County, especially African Americans. Thank you so much for having me this evening. I really appreciate it.
Oh, thank you, Samantha. I think for all of us as nurses, there's sort of a zen in our journey. And when it's time for a doctoral degree, give me a call. You'll be fine. So thank you so much. Well, here's another alumni from our PhD program in nursing at USD, Dr. Kiana White.
Hello. Thank you for having me here, Dr. Georges. When I got the email, it was a no-brainer. I had missed it. It had probably sent out a week before I saw it. And she's like, if you can, Dr. Georges, if you can't, oh, what do you mean if I can't? I will definitely be there. I will make sure that it happens. So my name is Kiana Jones, Dr. Kiana Jones. I graduated from University of San Diego in 2018. My background is pretty humble, actually, from humble beginnings. I went to a community college, graduated in interdisciplinary studies here in Los Angeles Southwest College. And then I proceeded to go to USC, where I received my bachelor's degree in health promotion, disease prevention. It wasn't nursing. And from there, I graduated and I went directly to UCLA, where I received my master's entry in clinical nurse, as we call it, MECN program. I was actually the very first class in 2006. Graduated from there in 2008. And that's when I kind of focused on my nursing degree. I worked at the VA for about 4 years before I started to venture in academia, which I'm still there now. Actually, some of my students are on, so hey, students, because we were supposed to have clinical today. So they're coming off their clinical hours, their 1 hour of clinical. And so I've been in academia since then. So it's actually 10 years this year. And also I have my own business actually in beauty and wellness. I've been in business for about 10 years. And I still work at the bedside 4 days a month at a large magnet hospital here in LA. I've been there for about 7 years. I just still always wanted to have my hands in ground zero, which I feel is extremely important, especially when you're in academia. So when I graduated, even during the time I was attending USD, I was still just kind of working at the bedside, and I was also working at a small community hospital in South LA as nursing supervisor, which I just resigned about 4 months ago. And so while I was just, making my commute once a week on Thursdays, 5 in the morning, just hauling down, this has been such an amazing experience. I know there's other universities here, but San Diego is just awesome. You guys have been so supportive. I actually was pregnant with my daughter, traveled down for that first year, had her at Christmas, came back in January. I mean, just all the support. So it is just, I appreciate you guys for having this difficult conversation, but much needed. And I'm so happy that you were kind of making me open back up my dissertation to kind of focus on this area.
Well, yes, and as I said to Trista, your dissertation also was very important work about the health of African Americans. So maybe we can describe it a little bit later, but
sure.
Thank you so much to all of you. I'd like us to just start an open conversation. And I'm going to share with you a response I received in an email from one of our alums to a letter which I sent out earlier this academic year. Following the public execution of Mr. George Floyd, I felt that it was very, very needed for us as a school to make a statement about racism and violence. And around that same time, ANA came out with their statement of racism as a public health crisis. An interesting email response I got was from one of our grads from the early 90s. And I guess we trained her well in research, because her response was, "You don't have any proof of that. You can't make that assertion." Yeah. And so let's start with that. Let's talk about evidence of health disparities across populations in the United States. Please jump in, any population you'd like to describe, any issue, including COVID. Are there documented differentials between outcomes, for example, for white Americans and their Black counterparts? And do we have that documentation?
I think there's plenty of documentation out there, the evidence to prove that there's a great disparity between African Americans and the rest of United States society. As you know, our comorbidities with diabetes, hypertension, depression, obesity, prenatal care with our young women who are pregnant. We're losing the battle. And with COVID on top of that, it really surmounts the problem. And it is a crisis. We are truly in a state of emergency. And as I spoke before, I experienced that situation with a family member just last month when we were up to deciding who's going to get a critical bed or not. And unfortunately, my son-in-law lost that battle because of age and his comorbidities. And, so it is a crisis.
I just want to, I've actually had conversations with people regarding the same topic, and it made me kind of dig deep as far as what's out there in the literature and what does it say. And I found it interesting that in 2003, our Institute of Medicine, they came up with they had this report about unequal treatment confronting racial and ethnic disparities in healthcare. And it outlined on a system level, practically every system that we have in the United States, which has shown that it has been connected to racism. And some of those examples are mortgage lending, access to housing, employment, criminal justice. All of those systems has had racial disparities that has been clearly documented. In 2008, the World Health Organization report on health equity led to our U.S. Department of Health and Human Services creating the social determinants of health framework. In addition to that, just if you come from a background, for example, as myself, where it's more humble, I'm from South LA, I've experienced it firsthand. So I feel like a lot of times we want to ask for the facts, and even when we provide them, they're still not received because the problem is people are not willing. You have to be in a position where you're ready to receive what you're asking and then be prepared for what you're going to do about it. Because once you provide those facts, then you have to know what your next step is going to be. And I think that's the most challenging time for a lot of challenging issue for a lot of people is, what do we do now? If we accept it, if we admit it, then what's next? And how does that look?
Absolutely. One of my purposes in having this discussion this evening is to ask the question, what next for our school? Because in my opinion and judgment, we're not doing well. So what next? That's a great question, and we'll go there a little later. Samantha, what type of health disparities have you seen in your own practice?
So within my own practice, I think I bring a different approach because not only working in as an intensivist in an ICU, but just working in San Diego Black nurses, like I said before, we do a lot of community service, specifically in the predominantly African American population, especially in Southeast San Diego, in National City, Lemon Grove, areas like that. And what we see is we see a lot of health disparities, specifically as it relates to systemic racism. And as Dr. White was stating, you know, this goes along the continuum. It has to do with racial justice. It has to do with access to good food, grocery stores. When you go into these neighborhoods and you see not having, the food quality is not the same, and the access to food, which has a direct correlation to health. When you have primarily fast food restaurants in these areas, you know, I've lived in an area of North County. I didn't even know where the McDonald's was. So I think that these are things that you really have to think about and have access. And this is a direct correlation to all the evidence that Dr. Campbell and Dr. White spoke of just a few moments ago. And then how that translates is into, you know, more detrimental health diseases that continue until, unfortunately, they see me as a result of continued problems and hypertension with strokes and cardiac issues, and they're in my ICU and they have a myriad of comorbidities by that time. So these are all real things. And like Dr. White stated, I think that the hard question is not just asking the question, but being prepared for the answer and ready to receive it. I strongly believe that we are all evidence-based providers, but there are some things that have absolutely nothing to do with how you can translate it in evidence. And we have to be willing to listen to someone else's story and believe their story when they tell you.
And if I could add, Dr. Georges, for the question to be asked, even without the evidence, open your eyes. You can go to any urban area and see that there is a clear difference and disparity in those communities. Now, I understand that we were trained about scientific evidence and what does the evidence suggest, but we also have common sense. And if you look and see, unless you believe that these people are just biologically inferior, then you know that the systems that we have in place are not advantageous for minorities.
Absolutely. I was very sad recently to read a very well-written and performed research study that documented in no uncertain terms that a major risk factor for an African-American infant is being delivered by a white physician. In fact, the odds of survival for that child are greater if the obstetrician or nurse wife is also African-American. And it's a huge disparity in infant survival. And I guess I just wanted to put that right up front as a forefront, that I got a little pushback that some people out of hand don't want to hear this. And you know what? It's time. It's really time for us to, you know, cope with this reality. Samantha, thank you so much for mentioning some elements of structural environments, because there's more than adequate documentation that people who live in what are called food deserts, meaning a neighborhood with only fast food and a liquor store, no access to fruits or vegetables, that their health is seriously worse than their upper middle class counterparts who might have access to that. So
yeah, there's many people here in San Diego, especially in Southeast San Diego, that drive outside of their own neighborhoods to buy groceries.
Yeah, and not everybody can do that.
Not everybody can do that. That's correct.
Yeah. Okay, well, I think that's a good starting place. And Samantha, I really appreciate what you said about listening to people's stories and believing the story. we often talk in qualitative research about the power of the narrative. And there's power in telling this narrative that, yes, in fact, this really did happen. So that's sort of the place we're in right now in nursing education. I'll be honest, very blunt. When I first went to the PhD program in nursing at University of Washington, I had never heard the word racism in a nursing classroom before, ever. It was invisible. I had been taught a lot of what I would call euphemisms, including cultural differences. But it wasn't until, and this was the early 90s, I felt like nurse scholars were really at least trying to address the fact racism matters and it is a huge contributor to Americans' health. I'd like to hear from each of the panelists, in what ways does racism affect healthcare delivery in the US? And I'd just like to hear your different viewpoints.
I can start if you like. I can speak from working at two hospitals who are essentially polar opposites here in Los Angeles. One being in an urban minority community considered a safety net hospital, and the other being in a more affluent area with celebrities and, you know, as their patients. One in which I was actually bedside and the other in an administrative capacity. And what I saw, I'm just going to give one example that really stuck out to me, and that is the way in which we label our patients from one side versus the other side. And at the small community hospital in urban LA, oftentimes when our patients are in pain, even if it was post-surgical pain, they were often labeled seekers, drug seekers. That was a common term that you would hear. And in nursing school, we're taught that pain is what the patient says it is. It's a very subjective, and although we try to quantify it, it is what the patient says it is, regardless of how they are reacting, what they are exhibiting, we say it's what they say it is. However, in the other hospital, the more affluent hospital, patients were often labeled as having a high tolerance. It was definitely a lot of excuses made for the amount of pain medication that would be administered, but the derogatory term of seeking was rarely ever used. It was high tolerance. It was that they were coping. It was always a reason, and an understandable reason why this particular group from this hospital, more affluent demographics, of course, primarily Caucasian, when they were experiencing pain, it was labeled this, which is more received as opposed to seeking. And so because of these labels, the management of pain was not as good in the more urban South LA hospital than it was in the affluent hospital.
Wow.
And that's just pain alone. I mean, I could go on, but that was one that just stood out to me, and how hard you have to advocate for your patients in urban areas where they are predominantly minority population, lower income. The first thing that's labeled is that they are seeking, versus more affluent, where they have a high tolerance. And so therefore we would administer more pain medication. That's just one example.
That is,
I just want to tag on to that. I think we even probably need to go upstream a little further, and we need to identify that when you're dealing with the Black population or minority population, we're talking about a majority suppressed, depressed society. Decades and decades of suppression and depression and racism. And how did these people get that way? Mm-hmm. If they are drug seeking, trying to self-treat and to deal and cope with day-to-day situations, to get up and go to work and face racism day in and day out with a smile and with gratitude. And I just think that these are the conversations we have to have. As you know, racism has been in this country since the day of this country existed. When slavery began, that's when racism began, and it goes that far. And I think this is a big onion that needs to be peeled back, and there's layers and layers and layers of a very complex problem, and it's not going to be resolved overnight. It took hundreds of years to get here, and I think the approach is going to be something that we need to start at the grassroots all the way to our Supreme Court systems, because we even have some Supreme Court racism issues that have been put into place, taking our rights away. So you can't really heal a body if you can't heal the mind. And I just think we need to change our, Dr. Georges had asked, how can we help? I don't mean to get ahead of you or off track, but one of the things in our curriculum, the way our insurance companies are set up, the way our health organizations are set up, you have your behavioral health and mental health across the street, but you have the physical, the medical system in this building here. And I think every time you assess a patient, you need to assess their mental status, their behavior status, because if they're not ready to engage in their health care, they'll never have quality health care. You have to approach them where they're at to begin to deal with the mindset and the environment that they're in.
Absolutely. Well, Trista, as always, I appreciate your very fine analysis, and Kiana also. Before I move on to Samantha, I'd just like to call out some particular strengths of some things you've said that I certainly want to keep in mind in the future. In Kiana's description of the drug seekers, and of course I've heard that term from other nurses, my research in nursing has to do with discursive patterns. So I'm always looking for patterns of language, particularly in ways that power relations are structured around that. And I have to say, I'd never thought of this before this moment, but drug seeker is, of course, a discursive term. And it is used by what some discursive scholars would say is code. Code means a way of speaking by a certain group. And they don't say exactly what they mean, but everybody in the room knows it. It's a code term. And so, Kiana, I think it's a very excellent example of drug seeker as code. It would never occur to me in a million years to say that a rich person has a high drug tolerance. Let's give them more. So thank you for pointing that out. Trista, your comment about the legacy of slavery is extremely important to all of us. For me, it's getting us to wrap our heads around as nurse educators, wherever we find ourselves, to understanding that some of our students are going to walk in our classrooms and they have been shaped by their environment, and they have not perhaps had a very rich liberal arts curriculum. Their worldview is narrow. And yet, as we move into an idea of nursing as a profession, which is autonomous, which is ethical, we are going to have to do some teaching of those students. The legacy of slavery matters. I remember the first time I heard those words in a nursing classroom, and I have to say I was very shocked. We need to get past that. So thank you for pointing out. I sometimes call it America's original sin. Thank you so much.
You're welcome.
Well, Samantha, have you seen ways in which racism affects healthcare in the U.S. in your own practice or experience?
Oh, all the conversation that we've had so far, Dr. White and Dr. Campbell, they brought up such important points, but also in just what you said about discursive language, like non-compliance. That's a big one we like to use. And that term is utilized a lot in the African American community. Oh, they're just non-compliant. Oh, they don't, listen to medical advice. And to some extent, perhaps, but we have to dig a lot deeper as to why. Why don't our patients perhaps listen to us? Are we not meeting their mark? I mean, a lot of times we look at our patients and put it on them, but we also need to put some of the responsibility on ourselves. We have to meet the patients where they are at and try to solve some of the problems that they have. As it relates to racism, even within, our nursing profession, this translating into treatment care, how we talk to our patients, how at a urban hospital, a patient's family or even a patient may not get the in-depth conversation that someone who's more educated and affluent will get. That time that the provider, the educator, the nurse, whoever's dealing with that patient and their family, they will take more time because perhaps they're a VIP, because they're a donor, because of all these different things. And that's not to say that I don't want to get into a practice of thinking that all African American people who have disparities are impoverished. They are not. I think that it's important to note that even for all of us, all three of us who are on this panel right now, we are at higher risk of having maternal death as a result of having children just by us being Black and just by us being educated. Our education does not change that at all. I mean, statistics and evidence has proven that. And so I think that it's important not to us just to put everybody in a box. And we have to really think about that. And for myself, there are so many stories of just my colleagues, my students, my just, across the continuum, whether it's my physician, nursing, academic colleagues, having to deal with, instances of daily microaggressions that can translate into real health disparities of psychological issues, mental health issues, being the strong Black woman. We fall down too. We need compassion too. We need a shoulder to cry on too. And so all these things that are kind of these discursive words that people use to identify people, at times you box them in and really do more detriment to them than good.
I think that so much wisdom in that. Anybody else want to talk about non-compliance is perhaps a term that's sometimes used?
I would say when you speak of non-compliance, I think a lot of it is fear and lack of trust. And it's not the desire to intentionally be non-compliant. I think many people don't trust the system. We have some history behind that we're still trying to overcome. And as you can see now, we're trying to get people to participate in our different research studies so that we can come up with a vaccine. And it's just the lack of trust. And we really try to continue to educate. I too am very involved in National Black Nurses Association, doing the community outreach projects and working with the smaller groups and trying to educate them and build trust and meet them where they're at to get them to participate in their wellness and the proper treatments for their different comorbidities. And it's an upward battle. And, but you just have to continue with the communication, and that's what, and it can't be done in 5 minutes. Sometimes we have to do it over and over again and begin to help them understand and trust. And one thing about the way our healthcare models are set up too, with the different HMOs, as soon as they get someone they can talk to and trust, then that person's no longer there. And so they're back at square one. So I think this is where I'm very passionate about advanced nurse practitioners in the healthcare setting. When I sat on the State Board of in Nursing in Arizona, we made nurse practitioners independent practitioners. And that's where, as we know, we're the most trusted profession. And I think if we had more models like that, where the nurse practitioner manages their patient populations and build that trust and relationship in educating our patients, I think we can move forward with some of the issues that we're dealing with.
I found that in my even my study, and I know we're going to talk about it later, Dr. Georges, but since you asked about non-compliance, my study focused on the lived experience of discharged and readmitted African Americans with chronic obstructive pulmonary disease to a safety net hospital. And what non-compliance translated in my story too was a lack of health literacy. So the people in my study who had COPD, they didn't want to be readmitted. They didn't want to not take their medication. They just lacked health literacy and did not have a clear understanding of what their medications meant, why they were important, when they should take them, how they should store them. I identified so many gaps in there and lack of literacy amongst my population that led to them being ultimately non-compliant, but it wasn't because they were intentionally non-compliant. They just lacked health literacy.
Well, you know, nursing has been saying for years, we want nurses to look like the American public. Nevertheless, number of people of color who actually are working as professional nurses, it is actually quite small. One of the participants has sent me a question, which is, how can more people of color be recruited into the health profession? Anybody want to talk about that?
I'd like to start off. So one of the things I wanted to point out as we were all telling our stories, there was one common thread. We all, from what I understand, none of us were bachelor's prepared nurses to start off.
Bingo.
Not one of us. And I think that that is very telling. We know, and the numbers have shown, that African Americans are not being admitted into Bachelor's of Science nursing programs at the scale of other students. And I think that that's kind of where we start. And that is not to take anything away from any associate program. That is not to take anything away from them, because I benefited wholly and clinically from my journey. But I think that we really have to look at that. That is telling. I think the advocacy has to start very young across the board, but particularly starting not just when people are in college already. I'm talking about when people are in junior high. That's when we got to start. We got to start with the math and the sciences. But that also goes back to systemic racism. And we know that schools in certain areas are not provided with the same funding. I was a single parent most of my career in nursing, and I always worked to get my daughter to certain zip codes because I understood that the schools there had programs that would allow her to grow and prosper. And so I think that that's important to recognize as we start thinking about how we're going to start changing things. We have to take a grassroots approach. And I think that schools need to start looking into junior high schools and high schools to start recruiting and start developing people who want to be in the healthcare field, whether it's nurses, PAs, physicians, whoever it is. And I think that that's how we honestly start changing it. In addition, I think that universities and schools need to look at their faculty.
Mm-hmm. Yeah.
The decisions that are made as it relates to nursing are made by 50-year-old white women.
Of course. Yeah.
And that is just the plain truth. There is very difficult to navigate as a woman of color in certain circumstances when you are dealing with perhaps someone who was the author of your letter, who stated that these things don't exist. They just don't believe that they exist. And it's very difficult to navigate, not only as as a professional who's already got a degree, but imagine how the students are impacted as well. So I think grassroots from a very young age, junior high, high school, ways to transition them into nursing programs, mentorship, education, and then helping facilitate them along the way. I think that that's really the way that we start changing the face of nursing. And then also give people a seat at the table. Mm-hmm. If your table does not look diverse, then you are failing to meet your mark. Period. Because there's more than plenty African American women are some of the highest educated people in the nation right now, no doubt. And so we really have to start looking at that.
And I was going to say, since you went to the primary level, I'm going to go to the tertiary level and say we also need to be mindful of how we are keeping nurses at the bedside, because Black nurses experience a lot of discrimination in hospital settings. And I know that's a whole nother topic, but I do want to throw that out there, because if we are talking about how do we improve healthcare, we have to have more people as far as African Americans who look like other African Americans and who can encourage other African Americans to become a nurse. And so a lot of times we have experiences that have led us to have a sour taste when it comes to bedside nursing. And it's something that has to be discussed. We have to talk about it, because what's going to happen is the landscape is going to change. Most African American nurses are likely to go to become advanced practice nurses, starting their own business. We're the fastest growing group of entrepreneurs, African American women. And so you have a segment of those nurses who are African American women also branching out into entrepreneurship. So that means that there are not a lot of us at the bedside, and for good reason, because of the treatment that we receive. So when we're not there, who's taking care of our patient? I can tell you numerous times where I have had patients who were African American who came into the hospital where I had to translate. And yes, they spoke English, but it's a different type of English that we speak. So we need somebody at the bedside who can advocate for those patients, and not just as the nurse, but it also as the cultural understander of what they are trying to relay to their physician or their healthcare team. So we have to also address those issues that are happening at the bedside if we want to, and it's across the continuum, of course, but if we want to combat racism in healthcare, it also has to do with the bedside nurses as well. And they're already nurses, but how do we keep them? How do we keep them at the bedside?
Yeah.
I'd like to add on to that as well. It's been a few years since I've been on campus, Dr. Georges, but I mean, the CNA entry level to the healthcare profession is a great way as well. I mean, if USD had a CNA program, that would be a wonderful thing, that you work with the inner city school, and this would be a great throughput, and this will create an environment where those who have to work their way through, like we all did, it's a way that they can have a job, flexible hours, and access to patient care to truly, they can figure out, is this really for them before they really get 3 years into a program? And it will really weed out those who are in it for the passion and those who are in it for the money. And we need more people in it for the passion. And I just thought the CNA program, another thing that's happened here when I was in Arizona, we made every nursing student had to have a CNA certificate to enter into the nursing program. It more or less established a baseline. You knew what the skill set was if they were a CNA, and you can build on that. And so, and then you're working for an organization, you can get tuition reimbursement and get on the career ladder and move up and never have to change your employer, but remain in school.
I think that's a great idea, and how much we need to think outside the box with ideas like that, because as near as I can tell, I'm being quite honest, and I have a bachelor's degree in nursing from the University of California. The California public education system seems to be set up to make sure that minority students don't get into UC, they get into community colleges.
Yes.
And I can say this after a lot of close relationship with folks who work in school districts. The deck is stacked. And by the time people are ready to graduate, oh, you might be a nurse. Okay, we'll go to this 2-year program. And, again, hey, associate prepared nurses, some of the best nurses I've ever worked with. Love them to death. But with that said, can't we bring all of us up to at least a bachelor's degree with the idea of a master's entry into nursing in time for everybody?
Yes.
But that would have to start, I think, in junior high. And I'm also wondering, Trista, if older high school students who are 16 or 17 might want to get a CNA
Yes.
certificate and start doing that part-time. If nothing else, it will give them a tiny leg up to at least have their foot in the healthcare world.
Yeah.
Yeah, I think that's a great idea.
Dr. Georges, if I could add on to that too, if we are trying to give them that leg up, then we also have to consider the systems that are in place as far as our educational system that basically has a foot on the necks of a lot of African Americans. This is something I realized when I was 16 years old, and I was talking to my guidance counselor about taking the SATs. I went to a school in South LA. We didn't have books. It was dangerous to walk even from home to school. We knew which streets to walk down. We had a lot of issues that we had to face before even arriving on campus. And my counselor told me, Kiana, you're smart. You should go to college. And I said, okay, what do I need to do? He said, you have to take the SAT. What is that? He said, well, it's an exam that you're going to take. And he explained to me what it was. And I said, well, who am I competing against? He said, all those who are in the same level as you. I said, wait a minute. So that means I don't have books. My school is not the same as everybody else's. So I'm competing against people with more resources, who can take the practice PSATs, who can hire a tutor. My mom can't afford that. How am I going to compete with them? So until we deal with all of those, also those issues that exist, we are not really giving them a leg up, because we have to address those issues that are at the core. This system that we're taking, this SAT, is one level of the system, educational system, that inhibits African Americans because we don't do well. Why? Because we don't have the resources to successfully compete in this competition. And so even giving them that leg up of, that transitional program, we have to also consider those other obstacles that they're facing.
Absolutely. I grew up in a house where there was a stopwatch on the dining table. And its purpose was for my dad to time us kids running through practice SAT questions. That's the house I grew up in. Not everybody grows up in that house. And I know from having gone to a California public high school that UC requirements are, they're pretty stiff. 2 years of algebra and other stuff. I saw time and again minority students being recommended more towards job training types of courses. So I don't want to give the idea at all that, being a CNA will solve everything. Yeah. You're right. It's the system itself. The deck is stacked. I can only speak for the University of California. I think it's great the Cal State universities have opened more BSN programs, but I'm not convinced that we're seeing more African American students in them.
Well, there are some things that are in place right now, even the Joint Commission coming out with different standards that your staff need to match the population that you're caring for, so that you become more culturally sensitive. I think as we use, these guidelines are in place, and if our HR departments really, truly recruit in that manner and hold them accountable for that as well. Unfortunately, we do know many of our big organizations get tax write-offs when they recruit minorities from out of the country. And so that also cuts us at a disadvantage. So it's just more or less being able to have these conversations and talk about the elephant in the room many times that people don't want to put on the table.
Yeah. There's an elephant I want us to get to before we finish up today. We've got about maybe 10 minutes left. We had I think it's a very thoughtful question from one of our participants. Nurse educators in the classroom, we think we cover things like social determinants of health and implicit bias. But this person is saying, how can we improve this? It seems inadequate. And I totally agree. Can you talk about perhaps some measures we might take to help All of us with implicit bias? Including our pre-licensure nursing students.
That's a big one.
That's a big, yeah. I thought it's quite an elephant, and that's why I said.
It is. However, you know, I'll use the term, you got to put your big britches on and begin to become thick-skinned and be able to initiate the conversations and be willing to be pushed back down, but you have to stand back up and begin to have those conversations. And there's power in numbers, and we have to pull ourselves together, like I said, at the grassroots level. But I remember when I first started my employment at, again, the big LA hospital, we had courses trained to have crucial conversations, conflict resolution. I mean, this was part of it, and it's all about caring. I think those different programs help me when it comes to having those uncomfortable conversations and being able to have dialogue with someone who was beginning to have incivility in the workplace, you know. But it is difficult. It is challenging because we have been taught to be nice and to smile, and we don't want to be labeled the angry Black woman. So we have to really have a skill set and able to move forward and to navigate, you know, this tortuous path, because it is pretty rough out there.
It's pretty rough. Go ahead, Kiana.
Oh, I was just gonna say, it's interesting that this question, because this was also very similar to one of the questions that was asked that Carol sent to us. And my response after I kind of thought about it, and I know one of the issues that we have as far as our own biases is that we don't take inventory of it. And so, and this is something that you have to dig deep for. It's not a lecture in class. It's not, you know, it's literally reviewing your entire life and those issues and those experiences that you've had where you have either allowed racism to be the topic, where you have laughed at a joke at the expense of an African American, whether you have not defended someone when you know that they should have been, you should have defended them. And so my answer to that question was, go where you feel uncomfortable. And I don't mean this only in the literal sense. I mean this in the physical sense as well. I believe the concept of racism has been overlooked because most middle and upper class groups live, work, and socialize within their comfort zones. So although your intention may be well, if you're, like, for example, teaching your kids or talking to your students to have respect and to understand their biases, but we have to consider also that we have the media and we also have others around who may be skewing your effort, your hard work. In addition, it's not only about teaching respect, it's also about teaching our students and our children to stand up for what's right, even when what's right may be uncomfortable and or in the opposite of or the opposite of popular opinion. So it's really, I feel like it's more than a lecture. It really requires some digging deep and having the students explore and find those moments that they didn't even think about, because it's so commonplace that they realize that they may have allowed or been complicit in acts of racism. And I do want to add that this is not just something that happens for Caucasians. This experience with George Floyd affected me also physically, because it rebirthed a lot of things and resurfaced a lot of experiences that I had that I suppressed, and times where I may have laughed or joked or, you know, allowed something to go that shouldn't have. So I do want to add that it's not just one group of people. I feel like we all, even those who are African American, have to have those conversations, and we have to speak to our own implicit biases and stereotypes. It doesn't mean that they're going to go away. It just means now that we acknowledge them, we will be aware when they present themselves. And then that gives us the tools and the resources we need to change and shift our behavior when that happens.
I think that is fantastic, Kiana. All of us, white people, everybody needs to dig down deep. And I'm thinking about what happens, the transactions that happen in our nursing classrooms. I mean, depending on the level, but for the most part, people are there to take down information and make sure they get every information so they can pass a test.
Right.
Whereas I believe the purpose of graduate education is to become comfortable with ambivalence, is to be aware that you can't know everything. And Dr. Oliver Osborne was an African-American professor at University of Washington. And I remember one day he said to our class of PhD and nursing students, who to a person, we're all white women in our 30s, every single one of us from a very similar background. Don't you ever get tired of just talking to yourselves? And we were like, what? You know? Sometimes as a professor, you got to take a stand. To be a professor does not mean you know lots of stuff. I think it means you're somebody who is willing to dig down deep. So I love that metaphor.
Well, Dr. Georges, I will say that I think the School of Nursing at University of San Diego does a wonderful job in putting together their cohorts for their groups. I mean, I had creating an atmosphere to have that dialogue amongst people who did not look like me, and the variety of age differences, race differences, coming from different parts of the whole state. I think that was the most valuable part of my learning experience during the PhD program. And that was done well. And I'm sure it was a lot of tabletop decision-making that you all did to create that, but it was wonderful.
Well, it's a tribute to the founder of our doctoral program, Dr. Patricia Roth, who is very committed to health equity. You know, she recently retired from our school, and we were all feeling that. But it makes me feel so good to know that we really do try to put together a class of PhD students who look diverse and are diverse. Anyway, thank you. That's Dr. Roth's thing. So
it is wonderful.
Well, as we finish up, we got about 3 minutes left. Dr. Joyce, this may open a can of worms at the very last minute, but I actually like it a lot. I think it's a good question. It's from a participant. What are the panel of females' thoughts? So now we're all in the same group on the disparity and gender racism experienced by Black males who are RNs who are struggling in a female arena. Anybody want to speak to gender disparity in nursing?
I think that I'd like to tackle that question. As it relates to gender disparity, I think that everything that we have talked about today is polarized when you're talking about the African American male. In every system across the US, they are targeted. And a lot of times especially in nursing, they have a hard time coping and deal with more microaggressions than even African American women. In a predominantly female-driven field, people who are fearful of, so this goes back to implicit bias a lot. And this goes back to having prejudiced thoughts. Kind of back to the previous question that we had. We know that this conversation is a conversation that African Americans have been having forever. And this conversation has not changed for us. The conversation has changed for everybody else in our community. So this task in changing things, as it relates to African American men and African American women having access to education and how they're affected, really has to go back to people who don't look like us. Those are the people who really have to deal with their social prejudices, because like Kiana said, we all have them. And that's not just dealing with white or Caucasian people. That's other people of color as well. We know that African Americans across the continuum in every race is thought less than. And that is just a pure fact. It does not matter if you're Asian. It does not matter if you're Latino. These are things that is just fact and true. The color of your skin makes you less than. And being a Black male definitely makes you less than. And that's how the whole movement actually started with the murder of George Floyd, because, you know, there was something, it has nothing to do with evidence-based. It has to do with humanity. It has to do with someone crying for their mother as they lay on the ground. And so understanding that this has to do with not just someone that we see as our patient, but these are people's sons and daughters that are striving to do better for themselves. And we have to deal with that on a humanity level, because that's what nursing is. We take care of people, we are human. And so all these terms that we use, these are all great, but at the end of the day, we need to treat people as we treat our families and as we treat each other. And if you would like to have the same opportunity afforded to you and your son and your daughter, then that's the same thing we have to give back to each other. And, you know, we use so many fancy terms, we have so many initials behind our names, but we're people. And we all want the same thing.
Well, Samantha,
Human caring.
beautifully said. I think it's a beautiful way to end our discussion this evening. I'd like to thank our panelists again. I can't imagine how crazy busy your lives are these days, that you would take the time to come share your expertise. And my hope is this is not just a one-off thing. This will be the start of future consideration by our faculty. How can we really achieve health equity for all Americans? That's our question. And nursing has a primary responsibility to do that. So thank you. Good evening. Everybody stay healthy. Kiana, do you want to say something?
Yeah, I just really quickly, I wanted to respond, and I wanted to leave it with this, because what you and Trisha was discussing as far as just slavery, and I know people, I've heard it so many times, well, we didn't do it, it's not our fault. So there's a book called Caste, The Origins of Our Discontentedness by Isabel Wilkerson. And she has this amazing quote as she compares slavery and our outlook of it now to new owners of an existing house. And she says, our immediate ancestors may have had nothing to do with slavery, but we are the current occupants of a property with stress, cracks, and bowed walls and fissures built into the foundation. We are the heirs to whatever is right or wrong with it. Any further deterioration is in our hands.
Thank you. Because I always think of America as the house I live in.
Mm-hmm.
It is our house. Yeah, Trista, please go ahead. Trista, do you want to say something?
No, I was going to say, I just said, well said. Well
I
said.
concur. Excellent way to end. Thank you, Dr. White.
Nice.
Thank you so much.
Thank you, Dr. Georges. Thank you, ladies.
All right. Well, I miss you guys. Thank you for
Thank you.
meeting. Samantha, it was wonderful to get to know you.
Well,
And we will look forward to moving forward together. So thanks so much for your time and energy this evening. Okay, take care. I'm going to sign off now. Bye-bye.